Good evening, sir.
Good evening.
Good evening, ma'am.
Madam.
Good evening.
Good evening, ma'am.
Good evening.
Yes, start करी दो वांधो नहीं. Sure.
So continuing from last lecture done by Kashvi about thoracic outlet syndrome, where she had covered the basic clinical anatomy and the clinical presentation and how to investigate the case of thoracic outlet syndrome and its varieties. I would be going about the surgical approach to thoracic outlet syndrome and also a few subclavian vessel related surgeries. So just a small recap of the interested field that we have here. So the brachial plexus arising from the nerve roots of C5, C6, C7, C8, T1 form the cords, trunks, and ultimately the divisions and the branches, all of which happens in the supraclavicular region and extends into the axilla. And it is between the scalene muscles that we have this anatomical arrangement. Anteriorly, we have the scalenus anterior, behind which we have the middle scalenus medius, and behind which we have the scalenus posterior. The interest of field is around the scalenus anterior muscle. Now, in this, the other structures of importance here are our subclavian artery and subclavian vein, in which the subclavian vein passes anterior to the scalenus anterior muscle, and the subclavian artery passes posterior. As you can see on this photo here, this is the first rib. The point that I'm highlighting here is the first rib. Then we have the pectoralis major muscles over it, under which there is the attachment of the clavicular head of the clavicular and sternal head of the sternocleidomastoid. And we have the subclavian vein, then the scalenus anterior attachment, the subclavian artery, the branch of the brachial plexus, and the further posterior relations. A clearer picture in this, where the anatomy of the subclavian artery and the subclavian vein are highlighted. As I had already mentioned earlier, the brachial plexus passes along with the subclavian artery in the arterial neurological triangle between the scalenus anterior and the scalenus medius muscle. And the venous triangle here showing the subclavian vein passing between the scalenus anterior, the subclavius muscle, and the costoclavicular ligament here. This being the clavicle and the lower part being the first rib. Now, why do we have so many issues, or why do we have the thoracic outlet syndrome? So there are various anomalies and variations in terms of the muscular and bony attachments, and also sometimes fibrous bands we hear which create compression, narrowing the outlet or the thoracic outlet. So the common anomalies noted are the splitting of the anterior scalene muscle around C5, C6. Then there is the possibility of a scalenus minimus muscle, which actually is present and attaches just posterior to the scalenus anterior, and it is compressing around the subclavian artery. Then we have the interdigitating muscle fibers through which the vascular or the neurological structures could get compressed in. The width of the scalene triangle could vary. A large width would not have any compressive symptoms, but a narrow scalene triangle would cause compressive symptoms. There can be congenital bands and ligaments, and also the possibility of a cervical rib. As we know, a cervical rib arises from the C7 vertebra and attaches either to the first rib or to the manubrium sterni, commonly to the first rib, compressing the subclavian artery and the brachial plexus. The cervical rib may not be a complete rib. It may have fibrous attachments, which also can cause compressive symptoms. The relation of the subclavian vein to the phrenic nerve is also one described, that if the phrenic nerve lies a little posterior or lateral to its usually described course, it can cause compressive symptoms on the subclavian vein. This, though, is very rare. And the relationship of the subclavian vein and the costoclavicular ligament, as I have shown here, if the vein is too medial in relation, and it can get compressed between the subclavius muscle and the costoclavicular ligament between the first rib and the clavicle. So the thoracic outlet syndrome, as we know, it has its own components of neurological, arterial, and venous. So in such cases, the patient may present with variety of symptoms as described in the previous lecture, and they can go on from symptoms ranging from the head, so starting from headache, shoulder pain. It can result in shoulder pathology or peripheral neuropathy, tingling sensation, numbness, motor weakness, and even can present as acute upper limb ischemia. So in such cases, the patient may present to a variety of specialists in our field. It can include starting from a spine surgeon. It may present to a thoracic surgeon once diagnosed. Patient may present to a vascular surgeon with ischemia. Patient may present to an orthopedic surgeon with pain, tingling, numbness, may present to a neurologist, or may present to an extremity or a hand surgeon. With the differentials being mentioned here of a carpal tunnel, ulnar nerve, peripheral neuropathy, shoulder pathology, subclavian vein thrombosis, each of which have been discussed in detail in the previous lecture. So in case of compression symptoms, just to give a brief outline before we go about each of them, is the share classification. Share classification is specifically mentioned only for arterial complications of thoracic outlet syndrome. This does not have anything to do with neurological. So we should remember from the previous lecture that the neurological component is about 70% of population presenting with thoracic outlet generally present with neurological symptoms. Venous and arterial symptoms are very rare, and arterial symptoms may be only in 3 to 5% of all those who have thoracic outlet syndrome. So out of the arterial, they can be of various stages. One of which, the starting of which is stage 0, where there is an asymptomatic subclavian artery compression. Patient does not know about it and may be found on a routine chest X-ray in the form of a cervical rib. There is stage 1, where there is stenosis of the subclavian artery with minor post-stenotic dilatation, but there is no intimal disruption. In such cases, patient is prone to subclavian artery thrombosis and to subclavian artery aneurysm, for which a decompression of the thoracic inlet as a prophylactic measure is indicated before the onset of complications. In stage 2, there is a subclavian artery aneurysm. The post-stenotic dilatation can result into an aneurysm with intimal damage and mural thrombosis. This mural thrombus can get dislodged at any time. Before it gets dislodged, it is identified, and decompression of the thoracic outlet with SOS, subclavian artery reconstruction, is advised. Now, stage 3 is when patient presents with an acute upper limb ischemia, where you have digital tip gangrene, or there may be gangrene of the fingers or the hand or even the forearm. This is because of distal embolization arising from the subclavian artery, as described earlier. In this case, an initial emergency thrombolysis or a thromboembolectomy is indicated as a limb saving surgery, following which decompression of the thoracic outlet and the subclavian artery reconstruction is required. So the approach to a subclavian artery or the thoracic outlet, as described previously in anatomy, there are multiple ways we can approach this place. This space is located just under the clavicle. So there are two common approaches, that is the supraclavicular approach and the infraclavicular approach. Later, as the cosmesis started gaining importance, the transaxillary approach was also discovered. A transaxillary approach was also attempted and is quite successful, especially in terms of neurogenic decompression. But in case of subclavian arterial surgery, where the exposure of the subclavian artery and its proximal extent is very important, in such cases, supraclavicular approach is most commonly applied. The infraclavicular approach is used mainly when there is an isolated, rare component, when there is only venous compression. So I will describe each of them in a little bit of detail. The supraclavicular approach, in which, as you can see, the patient is painted and wrapped, with the position being about 30 degrees of a head tilt, 30 degrees of a table up position, with the patient under general anesthesia and the neck rotated to the opposite direction. The upper limb is also painted and is also draped with sterile dressing, so that we can maneuver the upper limb in order to note the relation of the scalene muscles and the compression caused by dynamic move. In this, the incision shown here is the supraclavicular incision.
One thing you should also add, that upper limb is always draped, particularly when you are doing a vascular surgery, because the simultaneous brachial artery and embolectomy may be required. So it is always draped and prepared in all subclavian exposure should be kept in mind.
Yes, sir. So the supraclavicular incision mentioned here is a 1 to 2 finger breadth just above the clavicle, with its medial extent being the clavicular head of the sternocleidomastoid and the lateral extent being up to the external jugular vein. The another incision shown here is of the pectoralis minor incision, which I will be describing a little later. Would just be good to note that it lies in the deltopectoral groove at the lateral border of the pectoralis major muscle. So now a little bit in detail about the supraclavicular approach for thoracic outlet decompression. As you can see in the figure A, these are the structures here with the muscles, the vessels, and the nerves as I have described previously. The patient is positioned as described, and a transverse skin incision is made 2 finger breadth above the clavicle, and the scalene triangle is exposed. So now what are the structures that we will encounter once I open the skin, the platysma, the subcutaneous plane, and the investing layer of deep cervical fascia? The very important structure, as sir had also described in the previous lecture, is about the scalene fat pad, which contains the scalene, the fat, then there is the lymph node, and also a lot of lymphatics. And the dissection of this is important as there can be post-operative lymph leak, which can be avoided with meticulous scalene fat pad dissection and retraction. And occasionally the phrenic nerve could also be part of the scalene fat pad, which has to be carefully dissected and separated. So the phrenic nerve is the anterior most structure here, which lies anterior to the scalenus anterior muscle. In some cases, there can be an accessory phrenic nerve, or it can be in part, like it could be entrapped within the muscle belly of the serratus anterior, the scalenus anterior muscle, which is a very important thing to note. Patients undergoing thoracic outlet syndrome can have inadvertent phrenic nerve injury, which can be very debilitating in patients, even those with minimal work effort in their normal lives, in view of the diaphragmatic requirement. Then we can see here, this is the internal jugular vein, this is a subclavian vein, both of which are anterior to the subclavian, to the scalenus anterior muscle. Posterior to the scalenus anterior is the subclavian artery and the nerve trunks of the brachial plexus. Here they have shown the divided omohyoid muscle. The omohyoid muscle need not be divided in all the cases and would ideally limit our posterior dissection, posterior lateral dissection. The middle scalene muscle, as shown here, is the posterior extent anterior to which we have all the important structures. The middle scalene muscle is also divided, which I will be describing later. Shall I move ahead, sir?
Yeah, but remember, it is not always divided. Scalenus medius is not always divided. Particularly if you are doing only released, it is not to be divided. It may be required, particularly predominantly neurological symptoms. In a vascular symptoms, medius may not be divided in all cases.
Yes, sir.
Yeah.
The medius, as sir has also mentioned, is...
Have you discussed external jugular vein?
Sir, I had mentioned in the skin incision that was the general lateral most extent of our incision.
Lateral most, you should keep it in mind. That should be kept in mind, right? And yes, omohyoid need not to be removed. So many surgeons do remove it, cut it, but that is not required always. Okay. What about thoracic duct? What is the relation of thoracic duct if you are doing on left side?
On the left side, thoracic duct is an important structure which loops behind the subclavian artery and then comes anteriorly and attaches at the junction of the subclavian vein and the internal jugular vein from the posteriorly. An injury to this can be cause.
Have you shown it in any figure?
No, sir, I did not find it in any particular in any of the figures that I have mentioned.
Particularly on left side, that should be kept in mind. The only advantage is that it's like a phrenic nerve. It is one place behind. Should be kept in mind. So does it lie on sericus scalenus anticus or scalenus medius?
On medius, sir.
In medius. So that is the point you should keep in mind. There is no need. But yes, if you are doing for subclavian artery, be careful you do not injure thoracic duct. What will be the appearance of thoracic duct?
Thoracic duct is a...
Appearance of thoracic duct.
Appearance would be a greenish white structure in the...
No, green. Why it should be green? Why?
It's a white structure, not green.
It's a transparent beaded appearance. You should keep it in mind. Typical transparent beaded appearance. right? And
Okay.
it is very easy to mistake for a fiber and likely to be cut. So if you are aware of that and look for it, it will be all right. But it is one of the complication, but it should be kept in mind in some supraclavicular surgeries.
Yes, sir.
Suppose it get injured during surgery, what will you do?
So supposing it gets in, if we have to identify it and ligation of the thoracic duct should be done.
So the answer is always ligate. There is nothing like repair. So whenever it gets injured, ligation is the only treatment. Even if you come to know post-operatively, it is preferred that you should ligate. So when will you ligate it then? Suppose you are not aware during surgery, but after completion of surgery, later on you come to know that now there is a copious lymphatic discharge, patient is losing weight, and it's a very debilitating condition. It can go in a pleura and cause the chylothorax. So what should you do then?
So we will have to identify and ligate it proximal to the.
How will you do it? So that is the indication of thoracoscopic clipping of thoracic duct. That is the best option to find. Try to go again in and try to find it's impossible practically. Now, when the facility is available, best thing to do is a thoracoscopic ligation of thoracic duct. That is the treatment, particularly. Though in our what we are discussing in vascular and thoracic outlet syndrome, it is unlikely to be injured. Why? Because the anatomy is almost clear, very easy to find, and you can usually salvage it. It is more commonly getting injured some malignant disease, particularly thyroid malignancy or similar disease with lymph node. One rare which can cause is the retrosternal thyroid, which extends retrosternally and goes posteriorly, can create a problem. That should be kept in mind. And on right side, always remember, don't forget recurrent laryngeal nerve. Though
Yes.
it is lateral, but should be kept in mind, particularly when you are doing end-to-end anastomosis like that.
Yes.
Okay.
So going to the next step. So once we have identified our structures, that is continuing from the previous slide, the important slide is to mobilize. As we can see in this diagram, it is clear that this is the scalenus anterior muscle with the phrenic nerve on top of it. This is a jugular vein and the vagus nerve, if you can see in the yellow marking here. The vagus nerve lies anterior to the subclavian artery at its junction, at its origin, and gives the recurrent laryngeal nerve on the right side, which loops around and extends posterior to the subclavian artery. Then we have the parts of the brachial plexus. So then the steps in that parts of decompression of the thoracic outlet would be the division of the scalenus anterior. The scalenus anterior muscle is ideally done in such a way that there is no damage to the other structures. So the muscle should be mobilized from all its attachments in all directions. When the operating surgeon's finger should be behind the muscle, ensuring that there is no other structure in between, and it should be cut. The muscle is generally not cut flush to the rib. It is cut with a bit of musculotendinous attachment at the first rib. And as much as possible, the upper extent is dissected.
See,
and
Anand, before
Yes,
doing this, we have to isolate the phrenic nerve with the silk thread. Sometimes it is this phrenic nerve will come in the way. So you have to dissect out this which is lying over this muscle, and with the silk thread, thick silk thread, you have to keep it away before cutting.
Yes,
it
ma'am.
should not come in the way.
Yes, ma'am. As I had mentioned earlier also, that the phrenic nerve is lying immediately anterior to the muscle and sometimes can be in between the muscle fibers. The nerve injury should be prevented. The nerve should be, as ma'am rightly said, should be isolated and separated and kept either with the silk thread, ideally would be with the silk thread or a vascular loop, or as is available, cotton tape also can be used occasionally. Then the muscle is divided and the entire muscle is removed as shown in figure C. Now we can see that in some occasions there can be a scalenus minimus muscle which is also causing compressive symptoms which may have to be removed. Scalenus minimus muscle is seen only in 30 to 40% of all subjects and is not found in all patients. Then in case of neurological...
Welcome, Hitesh bhai.
Good evening, sir.
Welcome.
Yes, sir.
Please feel free to interrupt anytime.
Sure.
Okay.
આપણે ક્યાં ઇન્વિટેશનની જરૂરત છે?
ના તો ભી આ તો મેં જોયા તમને એટલે કીધું it is by
ના,
duty. Okay.
વચ્ચે મહિનો બધા હલવાયેલો હતો એટલે
હા, એટલે તમારા સિવાય બધાને કોરોના થઈ ગયો ખબર પડી, હું ફોલો અપ કર્યા. સારું છે બધું? ઓલરાઈટ,
બધા ઓલરાઈટ. પપ્પાને એડમિટ કરવા પડે તો હવે ઓલરાઈટ.
હા. આનંદ, કન્ટિન્યુ.
Yes, sir. So, continuing, the importance in case of neurogenic thoracic outlet syndrome would be...
Beta, there is a one thing, this is a little controversial. When you are doing it with thoracic outlet syndrome or a scalenotomy or a part of a cervical sympathectomy, there is no need to remove whole muscle.
Okay,
The muscle is usually removed for a vascular surgery. That is also some of the surgeon removed, but normally whole muscle is not removed, only the lower part is cut. One important point you should keep in mind is when you are cutting scalenus anticus muscle, it is easy to say that you can put your finger behind. It is practically very impossible, and you may are likely to injure the subclavian artery. So best way is to remove it fiber by fiber. Anticus has a lower part made of a tendinous, as it is seen in a figure B.
Yes, sir.
The reverse you should understand, that is in figure E. So that you should always remember, that is scalenus medius is reverse. It is more muscular at lower end, anticus is more tendinous at the lower end. So when you remove, what we normally do is remove it fiber by fiber. And when you reach the lowermost part, then take care of, because the many fiber, particularly in case of thoracic outlet syndrome or post-stenotic dilate, become adherent with subclavian artery. So it is very, very difficult to put the finger behind the scalenus anticus muscle. It is better, sometimes you can put a guard, but the fiber by fiber removal is better. And if at all you need to use, always in this place use bipolar cautery. Unipolar cautery is not advisable because of the close proximity to the phrenic nerve as well as brachial plexus. Though
Yes.
you can see it
And
is
one point what Pankaj Bhai is doing, he always keep the back of the forceps before cutting. So in some part when you have dissected, you keep the back of the forceps so you can protect underlying structure. Right?
Yes,
Okay.
ma'am.
And even bipolar, better to avoid, you can use knife. That will also be okay. Because for a beginner, as it is difficult to find facial nerve, it is difficult to be absolutely safe. The tendinous fiber will come in way, and you will feel that this is a part of brachial plexus. It has happened with everybody of us, those who are doing.
Yes, sir. So
I have seen.
Yes,
Pankaj Bhai. Yeah, I have seen, sir, you operating and splitting the scalenus antinus with a mosquito forceps and probably just pressing it for a few minutes and the bleeding stops. This is what I have seen.
Yes.
I never use cautery anyway. It is not advisable, but I use only forceps and fiber. It is cut. That is the best way to do it.
Yes, sir.
To cut it as a whole, as described in the book, is very, very difficult and likely to cause a problem.
yes, sir.
Right?
Yes, sir.
When you cut the scalenus, which vessel you have to take care sometimes?
So the transverse cervical branch of the thoracocervical
Not
trunk.
shown here, but you should always be careful. Our transverse cervical artery, which is a secondary branch from the subclavian. The
Yes.
problem will be if you do not tackle it early, it will cause the very massive field, and in such a small field, you can likely to injure vital structure. So never forget, along with the fat you have said, always transverse cervical artery, and even sometime vein.
Yes, sir.
And the one more point which books do not describe, but it is seen in 30% is accessory phrenic nerve.
Yes, sir.
Always take care of accessory phrenic nerve, which will be there in 30% of cases over the scalenus anticus muscle.
Yes.
The medial boundary is equally important. So what you normally do, you start from lateral boundary, and when you have not cut the scalenus anticus muscle, you will not be able to see subclavian artery. It is not easily seen. You understand? It is almost always buried by that. So best way is brachial plexus will be guide to you, and then come medially, find out the lateral border of scalene and gradually go toward the medial. The medial boundary will be phrenic nerve and internal jugular vein.
Okay, sir. So in cases of neurogenic thoracic outlet syndrome, there is a lot of fibrosis because of the compression causing inflammation, causing fibrosis. So a neurolysis is a procedure as described in the books, that it is to release the nerve fibers or the nerve roots and the trunks of the brachial plexus. Then there is the detaching of the scalenus medius muscle from the first rib. In comparison to the scalenus anterior muscle, the scalenus medial muscle is more fleshy and it has a direct muscular attachment to the first rib, does not have much of a tendinous component. This muscle is generally divided using the periosteum elevator directly at its attachment and not cut at its as the fibers. As sir mentioned just a while ago, that in all cases the scalenus medius muscle need not be detached. But in cases when there is a plan for the cervical rib or the first rib excision, then detachment of the scalenus medius muscle is an important step. As we can see here in figure E, there is the long thoracic nerve which lies immediately posterior to the scalenus medius muscle, and care should be taken to avoid injury to that, otherwise would be causing injury to the nerve and its complications.
Yes, this is the one point we many times miss, particularly when we have operated for cervical rib. When we operate for cervical rib, we forget the relation of long thoracic nerve, and inadvertent injury do occur occasionally because we don't know whether it is coming above the rib or not. And the second point is that when you cut the rib, the end should be made very smooth. So for that also, cutting of the scalenus medius is required many times. Otherwise, the rib will project from there. So it is an important point. And some cases, if you have not isolated long thoracic nerve or failed to secure it, the patient will have a typical post-operative pain in the shoulder. That has been observed many times. Okay.
Yes. So this was with respect to supraclavicular scalenotomy, which is more commonly performed for the neurogenic component. In case of arterial component, it is generally a cervical rib or its components, either an incomplete rib with fibrous attachment, and which generally requires excision of the first rib, the cervical rib, and the
wait. See, scalenotomy is usually done if patient is not having cervical rib, and if you have done MRI or CT scan and patient is having history of Raynaud phenomena, repeated Raynaud phenomena, in that case, on suspecting this is the scalenus muscle which is creating the problem, right? So scalenotomy is done specifically when there is no cervical rib.
Yes,
right?
ma'am.
Okay.
Specifically as part of, as you mentioned, ma'am, in absence, but in presence of cervical rib, this may be an initial step to approach the cervical rib also. So now I have described the resection of the first rib, which is done as part of decompression of the thoracic outlet. Now in this,
what is the indication of removing the first rib?
Ma'am, in case
specific indication. Normally patient do not require. In most of the patient do not require removal of the first rib.
In case of arterial compression, it is more likely to be requiring excision of the first rib. In case of or in cases of when there is a significant vascular compression and you require reconstruction of the vessel, in such cases the first rib needs to be.
The one is reconstruction of the vessel with arterial compression, or there is already thrombosis into the vessel, or in a patient who is having fracture of the clavicle and the rib. So those patients may require, because of the patient is having exostosis. So all these patients require particularly removal of the rib, because otherwise it is difficult to separate it from this vital structure. So in that case it is required, otherwise it is not required. Okay.
Yes, ma'am. Yes, ma'am. So in this photo, it is again showing the relations of the first rib. This we can see is the posterior attachment. Then we have the brachial plexus, the vessel, and the in brachial plexus, the artery and the vein. In this figure, the muscles have been omitted just to show the relation. And we can see the looping rib, which has posterior attachment here and an anterior attachment in this direction. In figure B, that is before of any of these steps, once the scalenus muscles have been separated, the scalenus anterior muscle separated at the tendon and the scalenus medius muscle separated at its base here, as it's shown at its attachment to the first rib. Then the separation of the intercostal muscles is achieved. Once the intercostal muscles are separated, the first rib is free from its upper and lower attachments, and it is still attached anteriorly and posteriorly. Anteriorly and posteriorly, the rib is divided, and the care should be taken to avoid injury to the structures that are very close to the rib in this location. In this location, anteriorly, the subclavian vein is a very important structure. The subclavius muscle is divided and the costoclavicular ligament may be divided. Okay. Usually the rib, manubrium sternum, and the first rib, the costoclavicular, the joint is paired and the rib is resected distal to the joint in both cases, as we can see here. And as sir clearly mentioned, the smoothing of the posterior end of the rib is very important. If it is not done, then there can be injury to the vessels, more to the and to the nerves, which can get trapped in formation of callus here. So smoothing of this posterior end is very, very important. In the anteriorly, phrenic nerve and the subclavian vein would form very important relations while removal of the first rib. Furthermore, the infra-axillary
There is another approach. You can go through the axilla also, supraclavicularly as well as through the axilla for removal of the first.
He is going to describe axillary route later on. I have seen it. In figure A, one structure is seen which you don't consider important. Which structure is that?
The phrenic nerve here, sir?
The phrenic nerve is shown. It looks very easy in this, but it's not that easy. Which structure? We have already discussed in anatomy. What about Simpson fascia and apex of lung? So where do they come in picture?
The Simpson's fascia is the condensation of the deep cervical fascia over the apex of the lung, separating it from the parietal pleura. So care should be taken separating it at the apex of the lung, that is just behind the subclavian vein at the aperture of the thoracic inlet or outlet.
Yes,
the dissection here is
upper diaphragm. Understand, Anand? As the lower, we consider lower diaphragm, which is fleshy. This is sometimes described as the upper diaphragm. It is adherent to the inner surface of the transverse process of C81 and inner surface of first rib. So if you have to cut the rib, you have to detach that Simpson fascia from inner surface and take care to put the lung lower down. That is without injuring the pleura.
Yes, sir.
So here they have not mentioned it because the Simpson fascia, in other words, is not that tough that you need to use the scissor or anything. But be careful that there is a definitely tough structure there which need to be taken care of. Otherwise, if you blindly cut the Simpson fascia, the chances are that you may injure the pleura also, apical pleura.
Yes. As they have kept the name fascia, but it is not just like a loose areolar tissue. It is a tougher structure, just like a tendon and the.
Yes, ma'am.
Yes.
Moving forward, I will just go ahead. I'll come to the complications of this approach at the end when I'll be covering complications of all the approaches. The other approach I had mentioned earlier was the infraclavicular approach, which is not commonly done, which is done rarely only for venous cases. I will be describing later. Before that, I will be describing the transaxillary approach, which ma'am just pointed out to. So the transaxillary first rib is.
Anand,
sir?
By chance, if you have injured the pleura, what will you do?
Sir, in this case, by chance you have injured the pleura, the possibility of a pneumothorax is very high. So in that case, in the books, there were two methods mentioned, which I read. One of them was to keep a negative suction and drain the air and close the fascia there. If that does not work successfully, then placement of an ICD will be required.
Okay. So what is that first method? We usually follow first method because we operate number of cases and hardly ever we need to put a intercostal drainage tube. What is that? How do you manage?
In that case, sir, we irrigate the field with saline and ask the anesthetist to give positive pressure ventilation, and we note for air leak. That would give us a confirmation that if there is injury to the parietal, if there is injury to the visceral pleura, releasing air from the lungs causing a pneumothorax.
No, but what will you do to tackle it? What is the first method? What is negative pressure? So remember, here we have, and most of the time, injury is very minute because it's very small hole inside. There is not much need of anything, repair or anything, which may be required lower down. So what is done is we put a catheter during closure time in that area and put the catheter under water seal. That means under saline ball or something like that. and ask the anesthetist to give positive pressure throughout the completion of surgery. When we have closed the nearby skin, you can withdraw the catheter gradually once the air leak stops. And in that circumstances, most of 80% of the time, there is no need for putting ICD. But if required, you anytime post-operatively, you can put ICD. So you can avoid in many patient ICD if you do, that can be useful in the lower approach also. When you are cutting 11-3 or 12-3 band, there is a pleural leak, this process can be done. That is a per-operative underwater seal, which will be removed when you close it. So keep that in mind. In upper part, we normally use that because most of the time, what happens is in anesthesia, the apex is not that distended. So sometimes even with the small injury, the pleura is spared and there is no need to do anything. And even if it is injured, it will be very minor and small hole, which can be tackled per operative also.
Yes, sir. There is also one theory that you minutely open the parietal pleura so that there won't be any hematoma which will be compressing the nerves, which can be detrimental. This is one theory. And most of the times this pneumothorax, which is this does not create pneumothorax because the air remains at the higher level and it will be a minor puncture and it will heal on its own. You don't need to put a drain in this vital area. You may open the pleura just little bit knowingly so that there won't be hematoma which will be compressing the neurovascular bundle.
Yes, sir.
Continue.
Continues. So the transaxillary approach is a cosmetic approach, especially more useful in terms of transaxillary first step resection for neurogenic thoracic outlet syndrome. This approach has the advantage of an incision being in the axilla. So the cosmesis is better, and the approach that it spares, it does not allow us to, but the problem with this approach is it cannot be used for adequate subclavian artery or venous exposure in case a reconstruction or a repair of the vessel is required. So in this case, as we can see, the position of the patient is 30 degrees with a head tilt and 10 to 15 degrees of a left tilt. The arm of the patient is prepped and draped, and it has to be held up either by an assistant or by suitable devices. So the incision is placed between both the anterior and posterior axillary fold, that is the latissimus dorsi medial extent posteriorly, and the pectoralis major lateral extent anteriorly, as is shown in the figure here. And the incision is at the level of the lower edge of the axillary hairline. Now, as we can see in these diagrams, the muscles are similarly exposed, and this is essentially a rib resection procedure. So the scaleneus muscles have to be divided. As ma'am mentioned earlier, that we can use the back of the forceps or a right angle forceps to safeguard the structures posteriorly, and the scaleneus anterior muscle is cut, the middle scalene muscle is cut, and after the
attachment, you are not pushing the forceps totally behind. Sir has told that you have to lift up these fibers and you have to cut it. So fibers by fibers, but just to protect posteriorly while cutting, you have to keep little bit forceps.
Yes, ma'am.
Totally, you cannot push behind. Right.
Yes, ma'am. Yeah, part by part is as.
Yeah,
right.
part by part.
So here the exposure once the rib is resected in a similar.
What is the incision site? Did you mention anything about? Sorry, I missed it.
Sir, I'll recap that. So the incision.
Between which two muscle the incision is put?
So the anterior extent is the lateral border of the pectoralis major, and the posterior extent is the medial border of the latissimus dorsi. That is the incision is at the level of the lower edge of the axillary hairline.
Okay. Anything else? Very important point. Don't miss it. Because I know that it is not done normally. The point what I would like to say, for a first rib excision, this is not a very good approach. Again, it is very rarely isolated first rib excision is required without reconstruction or anything. It is usually the very important incision used, particularly when you needed to do cervical sympathectomy, which isolated cervical sympathectomy we do not do now. If at all required, we go by thoracoscopy. So that was the reason this excision. But long thoracic now, don't forget.
Yes, sir.
That will come in an incision and you have to isolate and spare it. That is the most vital structure apart from thoracoacromion vessel. The long thoracic nerve need to be identified and separated before going inside.
Yes, sir.
Another problem with axillary, transaxillary incision is it is a very narrow incision. The maneuverability is not that good. And if any disaster occurs, you may have to convert for a large incision or even a supraclavicular. So it is nowadays not very commonly put. The one surgeon I have repeatedly doing it is Dr. Gunwant Rathod. He was very fond of it and used to do it. I have seen him doing it very nicely. But that's I have never done the transaxillary approach.
But so in that incision, what they were doing, that they were also cutting the part of the pectoralis major because they have to go through the thorax for doing this sympathectomy. So it requires cutting of the pectoralis also, part of the pectoralis. Okay.
Yes, ma'am.
Continue.
In this, the other structures that have to be carefully noted, as sir said, long thoracic nerve, the intercostobrachial nerve also comes in relation to this operating field and can get injured. The thoracodorsal nerve in its posterior extent can also get injured. This approach is also used for cervical sympathectomy, as sir also mentioned. I will be covering cervical sympathectomy in a later slide. So the other approach is the infraclavicular approach, in which specifically only the subclavian vein related structures are operated on. It is rare, it is uncommon, and it has been described in the book here. The subclavian vein, if in case of anterior rib resection, anterior first rib resection is done, following which a first interspace sternotomy can be performed. In this case, the sternoclavicular joint is paired. Like I mentioned previously, even during first rib excision, the sternoclavicular or the first rib sternum joint is paired, and this joint is retained intact, and the sternum is repaired again by using perpendicular wires, as shown in figure B. Coming to pectoralis minor.
Usually required in trauma. Always keep that in mind. These are the approach which are usually for a trauma.
Yes, sir. The coming to pectoralis minor tenotomy. In some cases, despite the usage of supraclavicular or axillary approach for neurogenic thoracic outlet syndrome, sometimes symptoms persist. In such cases, pectoralis minor tenotomy is considered, as the pectoralis minor muscle is suspected to be compressing on the nerve roots, not the branches and the cords in the axilla. The process can be taken out as part of the first surgery itself, or as the photo describes the presence of a drain and the incision. Sometimes it can be taken up as a second surgery in view of recurrence of symptoms. So the incision, as I had shown in the first slide, was in the lateral border of the pectoralis major muscle. It is a longitudinal incision. The pectoralis major muscle is retracted medially, as shown by the retractor in the diagram, and the pectoralis minor muscle is hooked underneath and held with the use of vascular loop or particular stay sutures. And the muscle is cut at its tendinous insertion to the coracoid process. That would be my completion on the operative management of neurological arterial and arterial cause of thoracic outlet syndrome. Okay. Further, I would be continuing my presentation on cases of approach to various arteries of the upper limb, starting from the subclavian, in case of trauma or other surgeries.
Okay, there are 2 or 3 points you should keep in mind.
Yes, sir.
The one point is, once you complete the vascular part of a scalenotomy or rib excision, operatively, you should always look for a improvement of pulsation and normalization of pulsation. One thing you should keep in mind. Once in a while, if you do not get, that would be an indication of doing a pectoralis minor tenotomy. Okay. Same sitting. Do you understand?
Yes,
sometimes, sir, beforehand, we know that the patient has an obstruction at 2 levels. You can also do the same thing at that time. The one more thing, I think sympathectomy, you are going to take it little later.
Yes, sir.
The point is, because it is a part of the surgery, you should always understand that it is isolated sympathectomy is practically obsolete. But okay, we'll discuss when we'll come to sympathectomy.
Yes.
Hitesh bhai wanted to say something.
Yes, sir. Though I have not done, but I have seen some videos. If you do it thoracoscopically, it is far better.
Yes.
Because if you have proper training and adequate instruments, it is far easier than transaxillary approach. And even because you get magnified view, you get the vessels easily, and you just need to incise the pleura, and then you get all the access. If it is the rib excision and scalenotomy is very easily done. Though I have not done, I have just seen the videos and few surgeons operating. It is a very good approach.
Pardon? I think we lost the initial part. What were you saying? Because of
Thoracoscopic approach. Transaxillary, but thoracoscopy, if it is done by thoracoscopy with proper adequate instruments, it is done very nicely.
It can be done. Yes.
Yes, sir. I have included that. I have
that we are going to discuss. That we are going to discuss.
Okay.
Naturally, the future is with that.
Yes.
Shall I proceed, sir?
Yeah.
So in cases of major vessel injury in case of thorax, in the thorax and the neck, the midline sternotomy would be one of the standard procedures in cases of the arch of aorta or the subclavian artery being injured at its origin. The extension of the incision, the initial midline sternotomy with the extension to the right supraclavicular region, can provide adequate exposure to the aorta and its main branches coming from the arch of aorta. That would be the right subclavian, the brachiocephalic trunk giving rise to right subclavian, right common carotid, left common carotid, and left subclavian posteriorly. This approach is more commonly used in cases of arch of aorta and right subclavian artery injuries. In case of trauma, the simplest thing is we need to get proximal exposure, and once we are able to clamp the vessel or take control of the vessel would be a better word, take control of the vessel more proximally, the easier the operation would be. Hence, in case of subclavian artery injury, this approach would be useful in case of transaction, or can be isolated and ligated at its base. Not isolated, and control can be taken of the vessel at its base, and further approach can be planned depending on the site and type of injury. In case of left side, the artery arises a little bit posteriorly compared to the left side from the arch of aorta directly, and the left third space interspace thoracotomy is ideal for the exposure of the proximal left subclavian artery. In this case, we have to remember that the arch of aorta lies very close in relation, and the vagus nerve loops are anterior to the arch of aorta giving the recurrent laryngeal nerve. So the neurovascular structures in this is complicated and is generally reserved to the thoracic surgeon in today's practice. But it would be very important that we should know where to approach the vessel from. In this case, it would be a left third space thoracotomy rather than a supraclavicular approach. This is a trapdoor extension in which there is retraction of the bony and soft tissue with a midline sternotomy. The left third interspace thoracotomy and a supraclavicular extension, which allows adequate exposure of the entire arch of aorta and the proximal part of the left-sided great vessels. In this diagram, this is the sternocleidomastoid, which has been divided here. Further, this approach can also be used in cases of approach to the upper part of the pericardium and the upper mediastinum, which can in case of injury. The subclavian vein exposure, as I had mentioned earlier, and as sir also reiterated, that it is more in cases of trauma when we want to gain access and control of the proximal part of the subclavian vessel and the brachiocephalic trunk. I would also be covering exposure of the other upper limb vessels. These are commonly employed in case of trauma, and also in case of vascular reconstructions and in case of brachial embolectomy. The axillary artery is very seldom approached except in cases of trauma because of its complex anatomy. As we can see here in the first part, the part A diagram, the axillary artery lies quite posteriorly in the axilla. The axillary vein lies anterior to this, and a complex neurovascular brachial plexus is there all around the axillary artery, the median trunk and the lateral trunk as shown in this diagram. The posterior trunk lies exactly behind the subclavian artery. It is very difficult to approach this artery and is avoidable in most circumstances. In cases of subclavian or axillary artery thrombosis, people prefer to use the brachial artery for embolectomy rather than using a direct axillary artery exposure due to its complex anatomy. The brachial artery exposure. I think this is a very common procedure performed in case of upper limb ischemia. I think most of us residents have also been exposed to this procedure in our rotation, and we have commonly been allowed to gain access and try to do embolectomy from this. This embolectomy from brachial artery allows us to gain access till proximal subclavian, sometimes the brachiocephalic trunk, and distally, if exposed at the level of this bifurcation, each of the radial artery and the ulnar artery individually can be accessed through the Fogarty. So brachial artery exposure is one of the very important structures. And also, as we see in trauma, a lot of our cases of vascular injury in the forearm, upper forearm or proximal arm or in the cubital fossa could injure the brachial artery, and it is important to know that where we should expose the artery to gain especially proximal and distal control. As the upper limb is high, has a lot of collaterals, in case there is a transection of the brachial artery, like we had a case in our unit, there was a patient who had presented with brachial artery transection and there was bleeding from both proximal and distal, and it is very important that we have to gain control of both the proximal and the distal in cases of upper limb vessels. So the brachial artery lies relatively superficial, and it can be exposed at the level all along its length along the humerus and also in the cubital fossa. The media, it is in this diagram, it is showing that it is exposed in the pronator teres and the flexor muscle mass. This is in the cubital fossa, and the radial artery can also be branching of the radial and ulnar artery can also be seen here. The median nerve is a very common relation which lies anterior to this vascular structure, and the biceps brachii muscle lies lateral to it. The radial artery exposed beneath the brachioradialis muscle and the pronator teres here, and in the distal part of the forearm in the location with respect to the radial styloid process. Here the vessel is relatively superficial, which we commonly use to palpate the pulse. And the importance of this exposure is in terms of formation of an AV fistula, which is commonly done at this site. The ulnar artery exposure. This is not very commonly done, but it can be used for a failed fistula using the radial artery or in terms of trauma, where it is found between the flexor carpi ulnaris muscle and the flexor digitorum superficialis. The ulnar nerve, as we can see, is a common accompaniment along with the ulnar artery. Coming to the thromboembolectomy as a procedure. So earlier, the two terms that we use commonly, embolectomy and a thromboembolectomy. The embolus is the usual initial formation of the clot, which has been dislodged from its primary source. So this primary source could either be the cardia, it could be the subclavian vessel, as described earlier, that the post-stenotic dilatation could form a mural thrombus and can get dislodged, or it can come, in case of the carotid, it can come from any vascular anomaly or an AV fistula. So this embolus, once it lodges into any of the major vessels, it can cause upper limb or lower limb ischemia. So once there is an embolus lodged at a particular point, there is further thrombosis formation distal to it. So that is why the term thromboembolectomy is used. The thromboembolectomy is a procedure done to remove this clot basically. Earlier the procedure done, better the results. Ideally, it would be best to do within 24 hours, but some surgeons and books also advise that it should be a procedure done till 15 days, where some amount of limb salvage could be possible. But the extent of limb salvage also depends on the presence of collaterals, which have continued to provide supply to the affected limb. So in this, I have shown in this diagram is the common presence of Fogarty catheter. So it has a tip which has a balloon at its end. So it's a balloon catheter similar to the Foley's catheter that we use. In this, there is the balloon is deflated completely, and the catheter is passed distal to the clot. And then the balloon is inflated, and along with the inflated balloon, the entire clot is pulled out through the incision. These methods can be done percutaneously or by open exposure of the vessel. Commonly, femoral embolectomy, brachial embolectomy, and popliteal embolectomy are procedures done. In these procedures, the vessel is exposed, looped around, and as we can see here, the vessel is looped and an incision is made. On arteriotomy, incision is made on the vessel. The incision could be vertical or it could be transverse. Transverse incisions are easier to close and are commonly employed in case of embolectomy. But in case the arterial vessel is diseased, or if there is a lot of plaque and the closure could result in stenosis, or if there could be requirement of a patch graft to close it, or in case it is suspected that an embolectomy would be failed and there would be need for a bypass at the same place, then a vertical incision or a longitudinal incision is preferred, and it gives the advantage over the transverse incision. So the incision once placed with pot scissor is widened and the Fogarty is passed. As you can see in part figure A here, that the Fogarty catheter is passed with the balloon deflated. The balloon is inflated distal to the clot, and with continuous pressure, it is gradually pulled out. The clot is pulled out. In cases of little delayed presentation, later newer technologies have come, which, as mentioned in the books, such as adherent clot retract catheter. So the catheter is designed a little differently in spiral shape, so that even the adherent clot is removed. Of course, this also comes with its due risk of potential tearing of the vessel and further bleeding from these proximal sites.
Rather than tearing of the vessel, it will give rise to injury to the intima of the vessel, right?
Ma'am, intima, as it said, that damage to the intima will happen irrespective. Even with Fogarty, intimal damage is common.
Intimal damage is always there. But
and
with
that is why,
that spiral catheter, there is always more injury to the intima.
Yes,
right?
ma'am. More damage definitely to the intima. That is why in cases of embolectomy or even arterial opening before the arteriotomy incision, we prefer to give heparin, the 100 units per kg body weight intravenously 3 minutes before the procedure. And
even you are giving distally also. You want to establish the backflow, so you have to inject distally also, and you have to infiltrate the papaverine over this vessel also to prevent the spasm of the vessel.
Yes,
right?
ma'am. Yes, ma'am. In cases of upper limb, especially where sympathetic activity is higher, where we are suspecting possible Raynaud's phenomenon also, as you mentioned, ma'am, papaverine or even glycerin trinitrate solution can be used and can be given surrounding the vessels in order to reduce the spasm, in order to dilate the vessels, where embolectomy procedure is done with a relative ease. But the procedure is quite complicated to prevent inadvertent intra-arterial injection, and that it requires an expertise of the surgeon to know its exact location in order to give it perivascular. This third diagram showing a graft thrombectomy catheter, it is specifically designed to remove thrombus from a previously present graft like PTFE or a Dacron graft, which has got repeatedly thrombosed. So the Fogarty catheter.
So what is the specialty in this catheter other than the routine?
Ma'am?
What is the difference in this catheter? When you are using this catheter for the PTFE graft, what is the difference? I do not know. I want to know from you.
Ma'am, I did not get too much detail about the technical differences between this graft, this embolectomy catheter and the standard embolectomy catheter, but it has lesser damage and it lesser shearing force in the transverse direction, and predominantly the force is in the longitudinal direction in order to cause dislodgement only of the clot with minimal damage of the surrounding vessel. I did not get further information about this. I will get back to you once I find something.
Okay.
So the Fogarty catheter usually comes from size 2 French to 7 French. The commonly used between 3 to 5. In cases of upper limb in radial or ulnar artery or digital arteries, a 2 French catheter is used. The 2 French catheter does not come with a bulb inside. The bulb is present only from 3 French onwards. So the 3 French, 4 French, 5 French, 6 French are commonly used embolectomy catheters, with 3 French being used for brachial, 4 French and 5 French for popliteal, 5 and 6 for femoral. And in cases of bilateral aortic saddle embolus, where bilateral femoral embolectomy is done, in such cases 6 or 7 French Foley's catheter, 6 or 7 French Fogarty catheter is used. Now coming to a short detail on the grafts, as sir wanted me to just mention upon a few of these grafts. These grafts, initially the best graft would be a venous graft that is from the same person, and the commonly used is the reverse saphenous graft. There have been present studies that the reversal of the vein may not be as important, and there are valvulotomes which are used to remove the valves in order that the same graft can be used. In case of coronary bypass, the radial artery or even the internal mammary artery is used. So the arterial graft would be the best, followed by the venous graft, followed by synthetic grafts. The synthetic grafts starting from the Dacron. These prosthetic grafts were first described in 1952 by Arthur Woos. Dacron was a material that was discovered in 1941, but was started to use much on later on. It was discovered by Winfield and Dickinson, and these come in two types, either in V1 form or in knitted form. So the knitted form has a lot of pores, and hence the graft needs to be pre-clotted with blood, or they come with the latest technology of being albumin coated. So the porosity of the graft is much higher here, and so the fresh blood of the patient before heparinization is generally withdrawn, and the graft is placed intraoperatively once opened in the blood, so that the graft takes up blood and the pores close. So the use of pre-clotted blood is important in cases of Dacron graft. These are large diameter grafts and can be used for aortic reconstructions and constructions of the. This is a Dacron graft as shown in the second figure. So, and they also come in terms of branches or in terms specifically, like this one shown here is used for aortobifemoral or aortobiiliac graft, where the proximal component is much thicker and goes in attachment to the aorta. The distal part attaches to the bilateral lower limbs and has a split Y-shaped graft. This is another graft showing which is used for generally for the aorta in principle in cases of aortic aneurysms. This is a PTFE graft, PTFE or ePTFE, that is an expanded polytetrafluoroethylene graft. It was discovered in 1973 by Matsumoto in Japan. These come in varieties of thin-walled, ringed, and pre-cuffed grafts. They are quite compliant, more easier to use, but are relatively more expensive when compared to Dacron. These come with the added advantage that these need not be albumin coated or pre-clotted with blood. But the disadvantage being it is little more expensive. There are also polypropylene and polyurethane graft, which are not very commonly used, but the thing that polypropylene, as used in sutures and in hernia mesh repairs, is a graft which is quite compatible in the human body. There are composite grafts and allografts. A human umbilical vein graft, as shown in this figure, is a novel technology which was started in the US in 1970s, but has been out of date, and FDA has disapproved its regulation and is no longer in use. It was last used in 2004. The bovine carotid artery graft and bovine mesenteric vein graft, as shown here, are xenografts, which have been derived from the bovine and preserved. So these grafts have to be preserved very carefully. As example, these bovine grafts have to be preserved in 1% polypropylene oxide in 40% ethyl alcohol solutions. So these grafts make it more difficult in terms of their preservation and usage. The human umbilical vein graft is very, very fragile and cannot be held very easily without the use of instruments. The injury to its intima was very high and was not worth of its use, hence went into disuse. Now, also with latest technology of grafts preferred to be used from human sources, such cryopreserved saphenous vein grafts or femoral vein grafts are there. But these cryopreserved come with its own advantages and disadvantages. Advantages being it is more human-like and it can suit well into the body, but its preservation and usage and its expense is a big disadvantage. Now, we also have bioengineered vascular grafts, which actually are based on tissue engineering. These can be made from biodegradable objects. They can be originated from xenogenic or from human sources. So these are scaffold-based grafts. Once the graft is created, and then there is cellular imbibition into the grafts, which make it easier for the uptake, and it has a very good theoretical application. But its use into the practical world has not yet been there. Now, with the advent of 3D printer, there is that it would be very useful and very easy for the building of the scaffolds is what is being researched at present. So hoping that these would come up in the future, but cost would be a very big factor in terms of its usage.
So there is one addition to this graft.
Yes, ma'am.
Whenever you are using popliteal graft, PTFE popliteal graft, they have prepared now new popliteal graft is with the spring. So normally, whenever you are keeping popliteal graft, you do not explain the patient that they should not sit in a squatting position or sit on the floor. They will not flex the knee completely. But because of this spring added into this PTFE graft, patient can sit or on the floor, or usually not advisable. But if patients, there will not be any disadvantage of flow obstruction because of that spring.
Yes,
so that is also available nowadays. Okay.
These, as you mentioned, springed or coiled grafts, as they're also called, ma'am.
Yeah.
These come in terms of to prevent the structure from external compression, where especially when it crosses a joint, as you mentioned, around the popliteal artery at the knee joint. It is also used, as sir had mentioned to me, that in cases of axillary or subclavian artery reconstruction, such grafts are used because in the movement of the shoulder, they should not get compromised.
Yeah.
So coming to the cervical sympathectomy. So the cervical chain starts from the superior cervical sympathetic ganglion at the level of C1, C1. But for us, what we are interested in, the interested for cervical sympathectomy would be the important one at the level of C7, T1 and the stellate ganglion. So, and from here on, as you can see, the first thoracic sympathetic ganglion. As Andarya sir also mentioned, that the thoracoscopic approach is gaining popularity with its low risk and high good exposure of the sympathetic chain. So in this, the common indications for sympathectomy are hyperhidrosis of the upper limb, which is common as mentioned in the books. Also as part of Raynaud's phenomenon or upper limb ischemia, as part of decompression of the thoracic outlet, sympathectomy can be performed. I'll be describing only in detail the thoracoscopic approach. This is a novel technology, and in this case, the thoracoscopy is done. In thoracoscopy for the sympathetic chain, the patient is under general anesthesia with a double lumen endotracheal tube, so that one of the lung can be deflated while the other is inflated. So with the side where we are taking action, that side of the lung is deflated, and the camera port is placed in the fourth or the fifth intercostal space in the anterior axillary line, as shown in this figure. Thus, working port is inserted in the third intercostal space, second or third intercostal space along the mid axillary line. In case we want a third port for excision, then along the just anterior to the posterior axillary line, another port can be inserted. So if you can see in this figure, this figure is showing the whitish beaded structure along just anterior, just posterolateral to the vertebral column and anterior to the costovertebral joint. This structure you can see here is the cervical chain.
So it is usually glistening white chain is seen, and along it is showing multiple fibers coming out from this chain, and it is lying on the transverse process of the vertebral body. Right? Yes, you will find out all these chain are lying on the vertically lying chain with lying on the transverse process of the vertebral body.
Yes, ma'am. So once the parietal pleura, as we can see here, is incised at the particular level, in cases of upper limb, where in case of hyperhidrosis, only T2 to T4 sympathectomy is done. But in cases where we are doing it for Raynaud's, even the superior the cervical ganglion is also included. So the parietal pleura is incised, and the branches of the sympathetic chain are cauterized, either with harmonic scalpel or mostly with harmonic scalpel, and so that and also along with its branches, the main trunk is also cauterized. As we can see here, the sympathetic chain section above and below the ganglia, and then the ganglia is cauterized. In this, the entire length along the mentioned spaces is cauterized. So in this, the patient, it is a relatively safe procedure in experienced hands with minimal collateral damage.
So once you diagnose that this is sympathetic trunk, you will dissect out the lower end first. That is the routine practice, that you dissect the lower end first, you divide it, and then with the forceps you lift up it upwards and dissect out all the fibers going laterally and medially from this trunk that you have to divide with this harmony. Right.
Okay. So And then the subclavian artery was my primary topic. I've also added a few points in terms when it is required in terms of aortic arch diseases. In this first diagram, I'm showing zones of the aortic arch 0, 1, 2, 3, 4. And this is with respect to a new technology called thoracic endovascular aortic repair, or TEVAR, TEVAR. So that is a technology in which the diseases of the descending thoracic aorta are encountered and tackled with endovascularly. So in such cases, if the endovascular stent or a balloon pump is used for aneurysms, it can compress the origin of the subclavian artery, especially on the left side, because its origin is the most distal. In such cases, the left upper limb is compromised in terms of its blood supply. Commonly, the left internal mammary artery would come as one of the branches of subclavian through its collaterals would compensate for this through the inferior epigastric vessels for normal patients, for those requiring minimal or sedentary lifestyle. But it may be inadequate in case there is an AV fistula on the left upper limb, or in case the left internal mammary artery has been used for coronary bypass, or if it has been damaged, or if there is an aberrant vessel, or sometimes it is atretic. So in such cases, a subclavian artery needs to be there has to be vascular flow in the subclavian artery. As the subclavian artery is very important in terms of, especially in terms of the vertebral artery, and it can result in spinal cord paralysis in case the vertebral artery flow is damaged. So in the second diagram, there is a carotid subclavian bypass being shown. The exposure being similar to the ones that I've described earlier. And the subclavian carotid or subclavian bypass in this Dacron graft has been used, and a graft, and if in case this is a planned procedure with TEVAR, in such cases the graft is performed first and then the vessel is blocked through endovascularly. But in case of emergency situation in terms of rupture or inadvertent bleeding, the grafting is the procedure of the aorta is carried out first, followed by the carotid subclavian bypass. Then there is a carotid subclavian transposition. This is a more difficult procedure in which the subclavian artery has to be mobilized in order it can be anastomosed in an end-to-side manner with the common carotid artery. This is also rarely can be used in terms of on the right side in case of aberrant vessel, in case the right subclavian originates from the descending thoracic aorta, compressing the esophagus, that we also called as lusoria, causing dysphagia lusoria. So in such cases, the reconstruction would involve a carotid subclavian transposition as shown in the third figure. So then there's subclavian steal syndrome. If there is an obstruction of the subclavian artery proximal to the origin of the vertebral artery. In such cases, the blood flow is redirected from the vertebral artery downwards, and hence there is signs of posterior cerebral and cerebellar insufficiency. This is a quite uncommon condition, but once diagnosed requires intervention. In this, it is showing carotid subclavian bypass with an atretic non-patent subclavian artery at its origin. This is also a complex procedure, and in this case, they have shown that this can be the internal lumen of the vertebral artery, and this is the graft being used as an end-to-end anastomosis with the graft here with the subclavian, and an end-to side of the graft with the carotid artery. This was one of the two are also part of subclavian artery interventions, and hence I have included as a concluding part of my presentation. Thank you.
Very nice.
Thank
Good.
you.
Okay.
Good presentation. Okay, thank you, ma'am. Thank you, Andare sir.
Thank you, Andare sir.
Thank you, sir.
I enjoy it as much as students enjoy. Thank you.
Thank you, sir.
Well presented.
Thank you, sir.